So when it comes to scleroderma, how many types of scleroderma do we have? Most commonly people say 2, right? Yeah, you have limited and then you have diffuse. Limited was always called CREST syndrome, right? And then you have diffuse scleroderma. But right now you actually have 3 types. Not just 2, but 3. So you have CREST, which is limited, and then you have diffuse, which is diffuse. There's one type with no skin involvement at all, but you'll only have internal organ involvement, and that's known as the SINE type, S-I-N-E. So scleroderma SINE type, only internal organ is going to be involved. So let's start with your limited first, right? When it comes to CREST, what does CREST stand for? What is C?
Hypercalcemia.
Calcinosis, so increased calcium deposition. Okay, what else? R for Raynaud's. So Raynaud's is when your hands, when you go in the cold, it's going to have vasoconstriction, becomes blue and then painful, right? Okay, E for esophageal dysmotility. S for sclerodactyly, your fingers are going to get all swollen and not. And then T for telangiectasia. Okay, now when it goes to CREST syndrome for Raynaud's, how do you treat Raynaud's? What is your dreaded complication you worry about in CREST syndrome? Pulmonary artery hypertension. What is the antibody that you would test for in CREST syndrome? Anti-centromere, ACA antibodies, which you'll check for. Okay. When it comes to the dreaded complication, they will definitely ask you about that. So how do you diagnose pulmonary hypertension? You don't always have to, you'll do an echo first. Get a basic transthoracic echo first, and your pulmonary arterial pressure needs to be greater than?
25.
It used to be 25, now it's? 35. So once you have a diagnosis from an echocardiogram, next step is to do a right heart cath. Why are we doing a right heart cath? Number 1 is to confirm diagnosis, but also to see if you can use a specific drug to treat them, right? So you want to see if it's vasoreactive or not. So you can give a substance and you see if there's vasodilation. What substance you typically give? You give nitric oxide or adenosine. You give one of these 2 drugs, and if the patient's arteries actually vasodilate, that is known as vasoreactive. If they are vasoreactive, you typically will treat with what drug? Why do we call it limited when it comes to CREST? It's about how much of skin is involved. Elbow below, not just elbow though, it's also knee below. So people always say elbow below and we forget the rest. So elbow below, but also knee below, but you can also have face affected. When you say diffuse, you'll affect all that, but you'll affect much more proximal abdomen and everything also. Okay, so that's going to be the key difference. So when it comes to diffuse, apart from having all this skin involvement, you're also going to have a lot of organ involvement, right? So what would happen to your stomach in somebody with diffuse scleroderma? So here, scleroderma can actually cause fibrosis of the stomach, but also the rest of the gut. So bringing that same theory of gastroparesis even further down, if the bowels are not moving, what happens? The bacteria starts proliferating, making more babies and having a party there, right? And so whenever you eat, what's going to happen? The bacteria is going to feed on all of that and cause explosive diarrhea, and this is known as SIBO, small intestinal bacterial overgrowth. How do you diagnose this?
That's hydrogen breath.
Hydrogen breath test. You give a carbohydrate load, goes all the way down, bacteria feeds on it, eats all the food, and then passes gas, which comes out of your mouth as hydrogen, and you feel the hydrogen in the breath test. When you do a hydrogen breath test, you can diagnose SIBO. How do you treat it? Typically the answer is rotating antibiotics, but the best drug to use is going to be rifaximin. What is the antibody test you're going to do for patients with scleroderma diffuse type? SCL70, which is also known as anti-topoisomerase, right? So SCL70 or topoisomerase they can give you. What is your dreaded complication of scleroderma diffuse type? Renal artery crisis. You'll have hypertension, really high blood pressures, and then you can also have microangiopathic hemolytic anemia. Even if your patient's kidney is shutting down really bad to a point of dialysis, would you still use ACE inhibitors? Yes, you don't care. Okay, you could be in dialysis, you don't care. Just go with the ACE. Okay, this is one of those moments when you can actually do it. ACE inhibitors all the way. The drug we like to use is actually going to be captopril because it's IV, titratable and whatnot. So if somebody comes with scleroderma to the hospital, does not have renal failure yet, would you start them on ACE inhibitors to prevent this from happening? Seems like a good idea, right? What do you use for idiopathic pulmonary fibrosis? Nintedanib, very good. Nintedanib is the drug of choice here. There's another drug called pirfenidone, but the preferred drug in interstitial lung disease with scleroderma is in fact nintedanib. Now, apart from that, your treatment for disease modification, you could use cyclophosphamide in these patients and azathioprine. So that's going to be scleroderma. Thank you for watching. If you like our content, please like this video, subscribe to our channel and hit the bell icon so you get notified when a video is released every week. Have fun studying. We'll see you on the next one.